Hello, my name is Jorge Galvez. I'm one of the Pediatric Hematology-Oncologists, a specialist in bone marrow transplant and cellular therapy at Nicklaus Children's Hospital, the program BMT and cellular therapy. Uh, Thank you for having me here in the, to do this presentation to discuss a very important topic in the Childhood Cancer Awareness Month. I want to walk you through our presentation, which is hematopoietic stem cell transplant and cellular therapy and current concepts and indications. We'll be discussing today the history and advances of the therapies. Brings us to 2019 as it is today. We'll discuss a little bit of the concepts of stem cells, the indications of hematopoietic stem cell, aplastic anemia, and cellular therapy. And we'll finish it with something that is very promising, is looking into the future, which is gene therapy and editing therapy. With this, let's start it. History and advances in therapy. And this slide we show on the left the number of transplants that have been done through the years since the concept of hematopoietic stem cell transplantation and cellular therapy started. And x-axis, we see how this have evolved through the years. If you can see the first arrow, everything started in the decades of the 50s and 60s. And then this started with Dr. Thomas Donnell, who is considered the father of the hematopoietic stem cell transplantation. When he thought for the first time to give a transplant to patients who suffer from either leukemia or severe aplastic anemia. And then next to it, one of the biggest discoveries as well that you can see in there, just right next to it, passing the 60s, is HLA typing. So HLA typing was discovered after actually Dr. Thomas Donnell used stem cells as a transplant. And this really teaches how to match better our transplants in patients that indications are there. Followed by that, I think another big milestone in hematopoietic stem cell transplantation has been the use of allogenic BMT for other conditions than severe aplastic anemia or leukemia, but it's also the use of allogenic BMT for non-malignancies. And that's the second arrow we see in the slide, which shows that allogenic transplant can be used for also primary immunodeficiencies. This was successfully achieved from a matched sibling donor in the 1960s at the University of Minnesota. It's an important landmark for the evolution of the field. The other important landmark we see here and how these therapies have evolved is the use of higher doses of chemotherapy to take care of a tumor and to have tumor killing. However, as a side effect of this, we will have something that will damage permanently the bone marrow. And that is what the third arrow says, using stem cells from the own patient to provide with stem cell rescue, and that allows to give higher doses of chemotherapy. The fourth arrow there is a continuation of the use of stem cells for patients who does not have malignancies, but also have hematopoietic stem cell disease or have a bone marrow disease, such as patients with sickle cell anemia or thalassemias. And then you see after the 80s and 70s and 80s, you see how the curve start picking up for allogenic transplant and for autologous transplant in numbers. When we go to the next slide, we see the same aspect when it comes to cellular therapy per se, because everything started with the use of bone marrow transplantation in the 60s and the 50s and the 60s. And for them to identify the components of the immune system and try to understand them and also manipulate them at the same time. As you can see at the very beginning, allogenic bone marrow transplantation, but it goes all the way to the right when you see in the 2000 with a huge explosion of science. You can see the use of T cells, of viral specific T cells, of T cell engineering for targeting cancer, for instance. And this is when the current chimeric antigen receptor is born, and the different models that you can see in the green boxes in there. Until we are right now as of 2019, and we were science is advancing that to the point that we are trying to tune our techniques in how to manipulate those stem cells. And that's what is considered a T cell gene editing or gene therapy. Let's move to the concept of stem cell and why we use it and why we have the potential of using stem cells. I think it's very important to understand the paradigm of what we do when we do stem cell transplantation. Many people always ask me if this is like a surgery or this is something that we need to bring the patient into the OR, and I say, well, it's something, a procedure that is very long, it's very complex, and also at the same time anticlimactic. But everything starts with the stem cells. And the reason is we need to grab those stem cells and we need to deliver them to a tissue. But we have to overcome that little narrow entrance that we see, which is the immune system. There's two ways because we're concerned about the immune system, because every time we introduce something immunologically different to another body, well, the immune system that belongs to the recipient will fight back, and it can eventually reject the graft. So there's two ways that we overcome this problem, or we overcome this obstacle, and then the first one is through therapy. So 2019, we use either immunotherapy to try to neutralize the recipient immune system, and also we use cytoreductive therapy, which is chemotherapy. We can also use radiation therapy, which in the newest studies, we're trying to avoid this because it can be very damaging for the babies and for the child. So that we're trying to deliver those two techniques in a very safe manner as now. And I think we're every year that passes, we're getting more good at it in the transplant field and all the community. Now, the second way we try to overcome this immune system check is through the best matching system, and any doctor, any transplant doctor will know that the best, and then also pediatricians will know that the best possible match for a person who is in need of bone marrow is of a sibling who is a full biological sibling, but it also shared this HLA typing system that we talk about. That was an important discovery back in the 60s done in France. And because when we match this immune system, the second concept basically tries to trick the immune system and make the immune system of the recipient, when it goes away, to try to be in harmony and in peace with the incoming new immune system. So those are the two aspects that we need. And this paradigm is the whole concept of how we can deliver stem cells. Not only hematopoietic stem cells, but we can deliver other types of stem cells, right? We hear about it, anti-inflammatory stem cells into the joint or into the spine, or to regenerate the heart, which is another huge field of stem cells, which is currently under a lot of investigation. Same we pass to the donor, mentioning how the donor is really important. I think that is particular to the South Florida population, where the minorities are actually the majorities. Is in my daily practice, I always encounter families who are coming from the places, or coming from the ethnicity background where it's difficult to find a donor. So we mentioned the 25% chances of having a full biological, full match biological sibling. So then what we do when we don't have that, when we start against the odds, so then we go to a registry, that it's the national registry, which is connected with international registries, and then we can reach any potential donor in the registry, like thousands of patients, thousands of people, volunteers in this registry. But as you can see in this slide, this registry has a lot of influx, of course, in well-developed countries, or in the registries are located in places where there's a population which is rich in white Caucasians, white Europeans populations. So therefore, we're in a place where there are minorities. And therefore, when we go into look into the registry, as you can see in the second line there, the green is represented for the chances of finding a donor, and then the blue is of course who does not have a match on the registry. And you can see Hispanics. Hispanics are, we can bring the odds of finding a donor to up to 80%. But there's a 20% chances that you will not find a donor. And I think this is important because it means that for every 100 patients that we see here, well, 100 patients that naturally another person will see at Latinos will probably have 20% of those one, or 20 patients will not have access to a donor through the registry. And this is percentages on a level of high matching, as it says there. We try to match those HLA typing antigens. I mean, usually we look at four different antigens, but 4 coming from the mother, from coming from the father, so like 8 in total. And that's why it includes also mismatches at the level of like not only 8 out of 8 full match, but also 7 out of 8. So you can see it's very difficult. And then the odds decrease when you go all the way to the bottom and you see populations like African Americans, which the chances of finding a donor is only 66% through the registry. Now here in South Florida and in Miami in particular, we have a lot of influx and diversity that we can see patients who are coming, I mean, they're only not African American, but they're Caribbeans. And that's why we see a little bit of more specific, the Be the Match has given us a little bit of a specific odds of finding a match. And I wanted to say this graph is very important to us when we encounter families who are with those background ethnicities, and to understand why it's so difficult to find a donor for them in some occasions. So on the left, you see what is the likelihood to find a donor, represented by percentages. And on the x-axis, you have the background ethnicity. And I placed 3 arrows there because I think it's important to mention the background ethnicity and the odds of those populations that we frequently encounter here in Miami. The blue bars, I just want to say, the blue bar represent, which is an 8 out of 8 HLA match. And then the green bar filled with green is represent being a little bit less strict and like saying, okay, we will take a 7 out of 8 match. But we know that the immune system will not be completely tricked during the transplant, and that can carry more complications. But then you see first arrow, it shows the Black and South Americans when are combined or mixed with Central Americans. That bar, if you follow the line and it goes there, and the blue line, it stops right. The level, the odds of finding a donor for a Black South Central American, it's like below 20%. Of course, when we get less strict, then we can see that he can have a 7 out of 8 HLA match, and the odds go all the way to maybe 65%. But of course, for 10 patients, 4 patients will not have a donor. So the second line you can see there is Black Caribbeans as well. It's very also complicated. Same thing, they can have below, right below 20%. And when you go into a less strict level of matching, and you are okay with a 7 out of 8, you can go all the way to 80% or 70%. And so on. The third arrow represents Hispanics. It's Hispanics, South or Central Americans. And then you can see that the odds of finding a full match are approximately 37, 38%. And then with less strict rules and taking a 7 out of 8, we can go all the way to between 60 and 70 and 80%. So moving into the presentation now, one of the other important things to understand in stem cells is like who needs a stem cell transplantation, right? And then because everybody, when I talked about stem cell transplantation, many people said to me, okay, so this is when the patients, typically the answer I get, this is when patients get leukemia, a type of leukemia that it doesn't respond to anything, and that's absolutely accurate. However, this graph will show you on the left that the different type of stem cell transplantations that we do in patients less than 20 years of age. And this is data from like 2009, 2010 from the CMBMTR, the Center, International Center for BMT. And then you see all the way to the right. I want to start with that big, in high, tall green bar who says non-malignant conditions. Because it's important because we use a stem cell not only for leukemias, not only for lymphomas, but for type of resistant cancers, but we also have another subset of patients that benefit from a stem cell transplantation. And I think this is important because those patients are seen by another specialties that they come across those patients, and it is important to have in mind that this patient might benefit from a bone marrow transplant, or it will eventually need a bone marrow transplant. To the right, and then it's staying in the graph, then you see all the way to the left, bone marrow transplant can be used in other type of cancers. And to the right, to the right, you see that ALL and the AML. This is the leukemias, whether it's lymphoblastic leukemia or whether it's myeloid leukemia. But you can see how the combination of all the non-malignant conditions such as sickle cell disease, Hurler syndrome, adrenoleukodystrophy, thalassemias, some sort of immunodeficiencies overcome actually the indication for transplant, the numbers of transplants or patients with leukemia. Now, when we keep moving more to the right on the bars, then we see situations like Hodgkin lymphoma or non-Hodgkin lymphoma, and then the yellow area represents something that we call autologous stem cell transplantation that we mentioned before, how we deliver higher doses of chemotherapy, but as a side effect of this higher doses of chemotherapy that eventually will kill the tumor, will have as a side effect a very important damage to the bone marrow, and that's what we call autologous stem cell transplantation. So there's diseases in where autologous stem cell transplantation is beneficial, high dose chemotherapy with a rescue. So what we typically do is before we go into those higher doses of chemotherapy, or even before the patient is undergoing more heavy therapy, we bring the patient to our unit, and we take those stem cells, we cryopreserve the stem cells, and then when we give those higher doses of chemotherapy, we thaw those cells and we deliver it to the patient through an infusion. And then we see the most common indications of this is brain tumors, because we need a lot of penetration to cross the blood-brain barrier. Higher doses of chemotherapy has indications like lymphoma, whether it's Hodgkin lymphoma or non-Hodgkin lymphoma, we have that. Conditions as a neuroblastoma too, very important, has shown to be absolutely beneficial and improve the progression-free survival and the overall survival of those patients. And there's other solid tumors that can be addressed with higher doses of chemotherapy with a stem cell rescue, such as germ cell tumors, such as some sort of sarcomas who is going in investigation to see if there's more benefit to this. Now, the other non-malignant conditions with the big and the tall green bar that you see all the way to the right is represented by primary immunodeficiencies. And this is important because those primary immunodeficiencies are detected, some of them are detected to the newborn screening program. So we use pediatricians in that community will get the famous newborn screen, and then within the newborn screen will be those like tracks, they're called TRECs, which are like those kind of like pieces of like of signals of signs of like the T cells are being educated, right? When those ones are very low and they're inexistent, then we have what we suspect might have the baby might have a primary immunodeficiency. And those patients have to receive an hematopoietic stem cell transplantation in a very safe but also fast manner, because a matter of time, well, those babies get a severe infection and cannot even make it to transplant. The other thing you see this is hemoglobinopathies, such as sickle cell disease and thalassemia are perfect examples of like indications. They're not malignancies, but of course, patients benefit from this and get cured through the transplant. And there's other hemoglobinopathies that are absolutely maybe rare, but we see them as well. The other metabolic and genetic disorders, and I highlighted one in there that I think is very important to mention, that has recently occurred a very important change in our newborn screen here in Florida as the last year, and it's the X-linked adrenoleukodystrophy, or what we call XALD. XALD, as we know, is it's a deficiency on an enzyme that cleaves the very long chain fatty acids through our whole body. So when we lack of that enzyme, all those long chain fatty acids increase in our body. Unfortunately, one of the places that increase the content of this substrate is in the brain. And when it happens in the brain, for reasons that we totally don't understand very well, patients might develop something that is called cerebral ALD. That, as is represented between parentheses in there, is fatal. It's a fatal disease with 100% mortality. So this is very important. This is so important that as of 2018, May 1st, the Department of Florida, the Department of Health, in the newborn screen program, has announced the beginning of testing patients with XALD. Because this is important, because if we're talking about a disease that will be fatal in 40%, 30 to 40% of the cases, then these patients need an absolutely immediate referral to a neurologist and to a BMT physician to do the proper screening and stuff. Because we never, we don't know, we still don't know who will be developing cerebral ALD. So it is important to remind this to pediatricians in the community also, that here at Nicklaus Children's, of course, we have a comprehensive BMT program that not only look for or do transplant for malignancies, but also address the transplant for non-malignancies. This is an important thing too that I wanted to mention. Now, how people ask, okay, how Jorge, the stem cell transplantation can be applicable to metabolic diseases, and this is a very nice explanation about how it works. And I want you to go all the way to the left. This is applied to Hurler syndrome. This is applied to XALD. It's applied to all those metabolic or enzymatic deficiencies that we can supplement through a healthy donor cell. So all the way to the left, you see the blue cell represents a normal cell. The normal cell, within the blue cell, there's a substrate represented by the little boxes, the red and the blue boxes that you see in there. And there's different enzymes, but there's one enzyme that would take this substrate and would cleave it. We'll like just divide it into pieces that the cells will metabolize, or will take care of those substrates in a better way, and then can get rid of them finally. So when there's those enzymes live within the lysosomes. I remember the lysosomes, those little capsules that deliver the enzymes and then metabolize everything that the cells internalize into them. Of course, when you have a patient with metabolic disease, with some of the metabolic disease like XALD, adrenoleukodystrophy, or Hurler syndrome, then you can see that the complex substrate is internalized into the cell. You can see in the red cells that is sick next to the blue one. It gets internalized, but when the substrate wants to cleave and divide, there's shown by the X there, the enzyme does not exist. Therefore, the substrates start, the cells continue internalizing the substrate, but it doesn't get cleaved. So it gets accumulated, and this is what causes disease. So the way a stem cell transplantation works in patients with metabolic disease, and this is a principle that was shown like many decades ago by important researchers and like centers, is in a normal, we can provide a normal stem cell that with a healthy donor who does not have the lack of the enzyme, who doesn't have the lack of this protein, and then once this cell is internalized into the body, it gets accepted, and then so this graph represented by the blue cell now to your right will also produce a normal enzyme. But one of the biggest discoveries in metabolic diseases is that cells have the capability to sit next to a sick cell, produce the enzyme, and deliver this enzyme into the microenvironment. That enzyme is eventually taken by the sick cell, and then that cell get internalized, that enzyme, and then you can see how that enzyme represented by the little e, the circles with a little e, gets internalized, and then it start cleaving, this followed by the second cell below the one above that, it can start cleaving the enzyme through a donor enzyme. So this is the principle how stem cell is applicable to metabolic diseases. And there's more under research about stem cells and their manipulation, and we'll be talking more about this in the slides of gene therapy as well. Now let's switch gears and let's talk about other conditions, and stem cell transplantation is very useful. It's very useful, and this is in the context of what I call bone marrow failure, that we have here in Nicklaus Children's a bone marrow failure, comprehensive bone marrow failure clinic that looks at all the aspects of why the bone marrow failed working. So as you know, the bone marrow it produces all the elements of the blood. It produces the platelets, it produces the red blood cells, it produces the white blood cells. But for some reason, in inheritance or for some acquired conditions, the bone marrow stopped working. And that's the case of aplastic anemia or inherited bone marrow syndromes, that eventually the bone marrow will fail. And what we see is when we do a CBC, we typically do this in CBC. The most common presentation of this condition is somebody gets a virus, a child gets a virus 2-3 weeks ago. The immune system tried to fight this virus. It interacts with the virus, but in attempts of destroying the virus, it creates a cross immunity. And for reasons that we don't understand, the immune system decided to attack. That's one of the theories, attack the bone marrow precursors, and therefore will end up patients having with white blood cells very low. And we typically look at the absolute neutrophil counts, and below 500 is what we call a very important neutropenia, or when the platelets are going from a normal number of has to be above 150,000, 200,000, but now they're reaching 60,000, 50,000, 40,000, and when gets significant is when there is less than 20,000 platelets, is when we call this is a severe aplastic anemia. And then when reticulocyte count, when your retic count, which is the counts of those immature red blood cells, it gets produced at a higher scale when the patients are in need of producing red blood cells. However, if the factory is empty, so you cannot produce any immature retic counts. Therefore, you will see it very, very low. And I always tell this and share this to students and residents, and also when I do presentations in the community, I said it's very important when we do a CBC and we identify one line disrupted or two lines disrupted, let's say platelets, or let's say red blood cell, white blood cell, follow with a reticulocyte count, because that will tell us how the bone marrow is working in many occasions. The next and definitive goal in help and how to diagnose really aplastic anemia is getting the tissue biopsy, going and taking a look how many cells are there, right? So treatments for severe aplastic anemia, and severe, when a patient is requiring transfusions, is a matched sibling donor. So if you have a full matched sibling donor, that's the way to go, because you don't want the patients to get any infection, right? However, we mentioned before that only 25% of the patients who has a sibling have the chances of doing this stuff. The other thing that you can treat is moderate aplastic anemia with immunosuppression. Try to decrease the level of immunity against the bone marrow. And that's what we do with immunosuppressive therapy with the ATG, cyclosporine. We try to kind of like reset, kind of like touch the immune system and say, stop what you're doing and let's see if we can restart the engine again. However, 66% of the patients will respond to this, and unfortunately, of those 66% patients, some of them might relapse and have developed a clonal evolution, something that we call kind of like MDS, like a myelodysplastic syndrome. This is a very important aid that I got from my training at the University of Minnesota. I think it puts it in a very important context. And then I circled two very important aspects, because there's people that come across those patients. I have patients that go to a plastic surgeon patient, and the plastic surgeon is very is very aware, see a problem with the thumbs, and it says, well, let's do a CBC in preparation for any surgery, and then you see some cell lines decrease, and then basically they diagnose patients with Fanconi anemia, Sherman-Diamond syndrome, or Diamond-Blackfan anemia. This is represented by the upper circle that I put, the right upper corner, which is those kind of features that you can see in patients with inherited bone marrow failure syndrome. And all the way to the left and to the left, and the bottom, I put multiple testing that those patients have to undergo in order to be diagnosed with any of those inherited bone marrow syndromes, because in pediatric, different than adults, majority of those patients will come with an inherited bone marrow failure syndrome. That has to be ruled out in order to deliver the best care, because that will dictate how do you manage those patients as well. And then to finalize, I think we're very exciting moment now in the cellular therapy and the stem cells is how do we manipulate the stem cell to make it more effective in treating disease. I think one of the things that we're talking a lot in the new era of treatment for cancer is how we use your own immune system, which we don't have to deal with the donor, we don't have to deal with this level of matching of the immune system, but how we can get your immune system, your T cells, how you can get your lymphocytes, prepare them, teach them, and then deliver them back to the patient, to the child that can target that tumor. And this is a huge effort from different research institutes and looking at the CAR T cells, so the T-CAR, which is the chimeric antigen receptor. And then you can see a lot of people say, oh, how does this work? How this is like nice? Well, it involves a very, very complex procedure in where everything starts with T cell collection. So first of all, you have to have the T cells. The patient have to have the T cells. We have to collect them. It has to be healthy. The healthy T cells, then those ones will go to something that we call cell transfection. And then this is the aspect of the gene therapy. We deliver genetic information to the cell, in this specific case to the T cells, to express something on the surface that we prefer to attack a specific antigen on a specific cell on a specific bacteria. In this case, for instance, how this was, how this exploded and was discovered was through knowing that the most common leukemia in childhood and also very common in adults is lymphoblastic leukemia from B cells. So then those B cells has a hallmark, which all the B cells, the way we recognize them is because they have a sign who is a cluster or differentiation 19. So then we said, if somebody get into this and say we're going to target this, we're going to deliver the genetic material into the T cell that can express this antigen receptor that will absolutely recognize the CD19. And that's what we call cell transfection. Then once we have this expansion of cells, and when we have this already modified engineered cells, then we transfer it to the patient. Now the patient, as you see there and below that little cartoon of the man, might still have to receive some sort of immunosuppression and some sort of cytoreductive therapy to give a space to those new T cells to come and engraft and then do the job that they need to do. Now, importantly is the patient monitoring, right? We need to be sure that there's a response to treatment, and how we do that, we do CT scans, we do biopsies. In the case of leukemia, we do bone marrow biopsies to make sure that this has been accomplished, right? In the next slide, what you see is how that design was done, and this is in the membrane of the cells, right? So you deliver the genetic information into the cell, gets internalized into the nucleus, gets internalized into DNA. Now the cell is engineered to say, now we're going to produce a cluster or differentiation for CD19, who's going to pick up the CD19, who's going to pick up all the B cells. And this is what is expressed on those surface that you see there. And then you have 3 different types of chimeric antigens who started all this huge research and also pioneer at the University of Pennsylvania. So you see complete remission in ALL. You use a retroviral. You can see there that there's a use of retroviral, and the second column is a use of retroviral, and in the third column there's a use of lentivirus. So you have to use those tools like lentivirus and viruses or retroviruses that can incorporate this genetic information into the T cells. But what is impressive is when you give treatment to patients that does not respond to therapy, and then has been undergoing a lot of chemotherapy, a lot of salvage chemotherapies, and then you introduce this cell, you can see that between 90 and 80% of the patient will be in complete remission in ALL. So that's pretty impressive, and it's very, has been a very important landmark as we saw at the beginning for the cellular therapies in childhood cancer as well. And we're learning how to do this of, let's say, a safe way, and of course at a more effective way, right? Because there's still 10% that you see there, 20% of patients that will still evade that leukemia, will still evade those therapies. So we're joining the efforts of the community to do that. Finally, I think what is very exciting at this time is the ability of cure diseases or improve diseases or improve delivery of therapies or improve more sensitivity to the current therapies is gene therapy or gene editing. And I think it's very important to understand how those therapies will work. Because I think a lot of people is talking about, you see in the past slide, you see the retroviruses, the lentiviruses, but there's now new technologies like the CRISPR-Cas that you can use without the use of integrating a virus into the DNA. You can use zinc fingers, enzymes, little proteins that can come, and you can tell to those proteins to go to the specific area on the DNA. They go into this specific area on the DNA. They cleave the DNA. They can take this piece out, and we can incorporate a new genetic material there that will be supplementing where the deficient is. Of course, this is young, and the field is still undergoing a lot of investigation. However, it has been utilized in diseases like XALD that we talked before. It's currently being used in diseases like thalassemias. So this is a very exciting time. Now, what you see here is the principle and the concept of like using gene therapy, because not only you want to replace what is not there, but in some occasions you want to enhance the gene, or you want to shut down a gene, and that's what we call gene editing. We don't necessarily have to cut the DNA or have to, but maybe interrupt the DNA. So for instance, in the followed by the schema with the little a, there is a person who is an HIV person who is infected as an individual. We know how the virus gets internalized into the T cells through a receptor. So the HIV will come, gets in a receptor, and gets internalized into the cell. This is called like the CCR5. Well, what you can do with gene editing is you can add those 6 fingers, and then you can grab the cells of the patient, grab the 6 fingers, and tell them, you know what, I don't want this CCR5 here in this particular cells that infect HIV. And as you can see in the all the way to the left in the purple circle, you see that the CCR5 has been obliterated because of the gene editing. So now when that is reinfused into the patient, therefore the HIV virus can no infect because it doesn't have the door of entry to the cells. So this is an application, of course, for gene editing, and as I said, it's a very exciting moment because people is really looking into this and working into make this more safe and for the patients. Now, in the little B that you have in there, of course, is different. If you have a hematopoietic stem cells, and then you can take that hematopoietic stem cell from the patient, right? And this is where the thing happens, and then you lack of something, right? There's something that is lacking in these hematopoietic cells, or there's something that you want to put in, then basically you go into, and then yes, so the way you do is you get the hematopoietic stem cells, and then you also genetically modify it, that they have the lack of something, right? And then it gets internalized, and that genetic material will express what is lacking or what is wrong. Let's say in this particular case, what we can see there is like severe combined immunodeficiency for a particular defect, which is the deficiency of IL-2R receptor. Of course, you introduce the receptor, and the receptor will now be possibly expressed through the hematopoietic stem cell who has been transferred to the patient, which is the own cell of the patient, not of the donor, and that eventually will give you normal cells as represented in the bottom aspect there. So I think gene therapy and gene editing is really a very exciting moment. I think it's important to us. Why? Because there's conditions such as sickle cell disease that are currently under investigation in adults, and it eventually will make their way to pediatrics, and we need to follow this very closely, because this would be, if it's safe, of course, it has proven to work in a very nice way, in a very safe way. This would be very important for our community here in Miami, as we see a lot of patients with sickle cell disease as well. So with that, I finish my presentation. I wanted to say thank you for joining us, and if you have any questions, you can put them on the chat there in the chat box, and I can answer those questions at any time. And this is my contact information here at Miami Children's, and you can email me. Please feel free to email me with questions. I get my emails all the time on my phone, so I'm very happy to communicate for questions or doubts or concerns or discussions. Thank you so much.